question. Again, I hope everyone has their lab manual open. We're going to do 2 labs together tonight, the blood pressure lab and the central venous pressure lab. The central venous pressure lab has, well, you're going to see me in the video, but mostly my husband, who was my little guinea pig for making that video. And that was the very first video I made when we first had this pandemic and our school went into lockdown. So it was one of the very first labs that we had to go and put online. Let's start with our blood pressure lab. All blood vessels have a blood pressure. They all have it. But the vessels closest to the heart, the arteries closest to the heart, will have the highest blood pressure. Now, one of the earliest scientists to study blood and blood pressure was Stephen Hales. And in this picture, you can see him standing up on a wooden box, and he's holding a very long glass column, a glass tube. And in that tube was mercury, like the liquid substance in a thermometer. And at the bottom of the tube, there was some plastic tubing that was connected to the glass tube. And then he took a large cannula. That's a nice word for a very large needle. And you can see this horse is laying down on the ground. And he took this large needle and he stuck it into the horse's carotid artery. And every time the horse's heart contracted, when the ventricles contracted and there was a stroke volume, the column of mercury rose. And when the horse's heart relaxed diastole, the column of mercury fell. And Stephen Hales was the first person to say, okay, here's systolic pressure. When the ventricles contract, this is the blood pressure. And that's the reason why we take blood pressure in the units, millimeters of mercury. And when the horse's heart relaxed, the column of mercury fell, and that was diastolic pressure. So again, all blood vessels have a blood pressure. The arteries closest to the heart have the highest blood pressure. Why? They're closest to the heart, and they are receiving more of the stroke volume. Certainly the aorta, for example, is receiving approximately all 70 milliliters of a typical stroke volume. The aorta is an elastic artery. It is well suited to expand, to receive all of this blood, and then it recoils because it has elastic property. And as the blood vessels recoil, this pushes the blood further down the vasculature. This is the reason why our blood continues to flow, even when our heart is at rest. So again, all blood vessels have a blood pressure. What is blood pressure? It is hydrostatic pressure. It is a pushing pressure. The blood inside the vessel is pushing out on the vessel wall. And the vessel in turn is squeezing in, pushing in on the blood inside. A person can have low blood pressure, maybe because they don't have enough blood volume. Not enough blood volume because maybe they're dehydrated. There would not be enough pushing out on the vessel wall. Another person can have low blood pressure if their blood vessels are overly vasodilated. If they're vasodilated, there isn't enough pressure on the blood inside. It's a lot like when you tie your shoe. Have you ever gone running and you stop to retie your shoe because it's just not tight enough? Your foot might be slipping out of the heel. It needs to be snug. You like to feel that real tight tennis shoe. Or maybe it's too tight and the circulation is being cut off to your foot. That's how I like to think about blood vessels when they squeeze on the blood inside. We don't want it to be too much or too little. We need it to be just right to make sure that blood continues to flow. Now, in this picture, you're seeing all of the blood vessels have a blood pressure. And you can see the blood pressure is highest for the aorta, which is closest to the left ventricle. And we also can see that there is the steepest decline in the arterioles. And that's because the arterioles are called the resistance vessels. They are going to put a very good squeeze on the blood inside. They don't have a lot of elastic tissue. They're not very good about expanding and then recoiling. They're like the vice grip on the blood inside. And that is where we get our steepest decline in blood pressure. Blood will only flow from high pressure to low. In order for blood to flow from the aorta to muscular arteries, the aorta must have a higher pressure than the muscular artery. In order for blood to flow from a muscular artery to a smaller artery, the muscular artery pressure must be higher. In order for blood to flow from a small artery to an arterial, the small artery must have a higher pressure than the arterial. Blood will only flow from one vessel to the next if the upstream vessel has a higher pressure than the downstream. If the vessels are matched in pressure, there is no pressure difference, there is no gradient, and there will not be flow. The blood will just pool, and we call that stasis. In order for blood to flow from arterioles to the capillary beds, the arterioles have to have a higher pressure than the capillary bed. I think you get the idea. There is a test question on that concept. Blood will only flow from high pressure to low. That means the blood pressure constantly has to drop from one vessel to the next to ensure a gradient. Now, how does blood flow? Meaning, in what kind of pattern? Well, in tube A, you're seeing that the pressure is the same across the tube. And if there is no pressure difference, notice that the blood is not moving. In tube B, there is a higher pressure on the left side of the tube and a lower pressure on the right. So this is lower. I'll say it's pressure 2. And you can see the blood is flowing in a laminar fashion. And we see this parabola where the center of the blood in the middle, I should say, of the blood vessel is faster. It's experiencing less drag. And I hope you have watched your PhysioX number 5, where I talk about why vessels that are longer and have a smaller diameter have more resistance to blood flow. There is more drag for the blood touching the vessel wall. It comes into contact and it slows down those red blood cells. Then down here in tube C, you're seeing turbulent flow. You're seeing swirls and eddies. And turbulent flow is interesting because turbulent flow is going to produce sounds. And tonight, when we learn about taking blood pressure readings, one of the ways we're going to do this is through auscultation. Auscultation. And that means the art of listening. We're also going to do another technique called the palpatory method. That means to feel. And one of these methods is more is more accurate than the other. You're going to learn that tonight. So the turbulent flow is blood flowing in a swirling fashion, and it's this turbulent flow that we are going to use to our advantage in the auscultatory method to hear when we take blood pressure readings. So let me tell you about this auscultatory method first. Here's how we take a blood pressure reading. I'm going to describe it to you, and we will watch a video on it. Perhaps many of you out in the audience already know how to take blood pressure readings. And if we were face to face, I would say, hey, I need you tonight. I need you to be my co-teachers. And we have actually a stethoscope that has two ear sets. So it is easy for a student to teach another student on what to hear for that auscultatory method. So here's how we take that blood pressure reading. We put the sphygmomanometer cuff around our patient's brachium on the left arm, ideally. And it's going to be above the antecubital fossa, above the inside of your elbow. So we put the cuff here. I'm sure all of you have had your blood pressure taken before. And aren't you glad that we have a non-invasive way to take blood pressure readings now? Could you imagine if we still take blood pressure readings the way Stephen Hales did on that horse? No one would want to go to the doctor if it meant getting a needle into your carotid artery, would you? You would never go. Okay, so we put the cuff around the person's brachium and we inflate the cuff. When we inflate the cuff, it applies a pressure on your patient's arm. When that happens, it occludes, it basically closes your patient's brachial artery. When the cuff pressure is higher than the blood pressure shown here, when the cuff pressure is higher than your blood pressure, so here's your blood pressure, and your cuff pressure is higher than that, there is no flow. There is no blood flowing. And on your lab exam, that is going to be labeled with a letter A. And then we're going to release the cuff pressure. And as the cuff pressure comes down, shown here with this pink line, when it first dips below systolic pressure, and this point right here is going to be marked letter B on your exam. I use the same picture, but with no words on it. You're going to hear a heart sound. I shouldn't say a heart sound. You're going to hear a turbulent sound. You're going to hear a whirling sound. Every student describes it differently. Some students say it's a thumping sound. And as that cuff pressure continues to drop, when it finally drops below diastolic pressure, the brachial artery has gone back to its open position, and the blood flow through the brachial artery is now laminar. Laminar flow does not have a sound. So when you lose the sound, that is the moment when you would take diastolic pressure. So when do we take systolic pressure? When we first hear a sound. We look at the dial and we write down that systolic pressure. When we lose the sound, that is diastolic pressure. These sounds have been characterized. They're called Korotikoff sounds. And they have even been characterized according to their intensity, like a whirling versus a thumping versus a muffling. I don't have the ear for it. I always find it fascinating that some of my students that play a musical instrument and can hear the different tones in music, they have the ear for these different sounds that we can hear for blood pressure readings. I do not have the musician's ear. So I just hear a sound and it usually sounds like a thumping to me, like actually more like this. And then when I lose the sound, I know that's diastolic pressure. Okay, do you have your lab notebook? We're getting ready to start collecting some data. The other way we're going to collect data today for blood pressure is the palpatory method. And I want you to pay attention to the dial because you're going to pretend that as you watch these videos, this is you taking someone's blood pressure. And the palpatory method means you're not using a stethoscope. And how it's different than the auscultatory method is you again inflate the cuff. There is no longer any blood flow through the brachial artery. You place your hand on the person's radial artery, which is best felt here in the anatomical snuff box. Don't use your thumb to feel for a pulse because your thumb has a large artery that goes through it and you'll feel your own pulse. So usually use your index finger. Some people like to pinch the radial artery here. I like to use, anatomy was a prereq, the anatomical snuff box. And the anatomical snuff box is if you abduct your thumb, you see that indented region right there? That's the anatomical snuff box. And the radial artery is very superficial in that little area. And they called it the anatomical snuff box because people would put their snuff and snort it in that little pocket of their thumb. So the palpatory method is not as accurate as the auscultatory method, and here's why. It's going to underestimate the patient's blood pressure. And the reason is that as the cuff loosens and blood returns to the brachial artery and blood finally reaches your radial artery down here by your thumb, the dial on the needle on the dial has gone down quite a bit. By the time you feel that pulse return, and then you say to yourself, oh, I feel it. Now I should look at the dial. It's gone down about 20 to about 30 millimeters of mercury. That is greatly underestimating someone's blood pressure, but it's better than nothing. And in the video, I think it's in this video, the instructor says it is about a 20 to 30 millimeters of mercury underestimate of the actual person's blood pressure. Okay, some people profess that they can feel a difference in the pulse intensity and they can feel the difference between systolic and diastolic pressure. I would refrain from this belief. You really can't feel a difference in the intensity. No, you cannot. And in fact, I would run from a nurse if a nurse tried to tell me that he or she could feel the difference between systolic and diastolic pressure in my radial artery. I would be suspect of that person. Okay, so I am going to click on these video links. Please get your data or your notebook ready to take some data. And I will do my best to pause the video so that you can look at the dial and take down some of your readings. Okay, so let's watch this short video first that demonstrates the palpatory method. Excuse the ad. Can everyone see the YouTube video right now that I'm about to begin?
No.
No.
You cannot see it?
Mm-mm.
All right, then hold on, please. I never know when I navigate away how much you're following me when I navigate away. That's why I ask. Now, can you see?
Yes.
Yes.
No.
Okay, thank you. Okay, so very short video just to show us what the palpatory method looks like.
This is how you palpate a blood pressure. The reason for palpating a blood pressure is primarily because you cannot hear or auscultate for a blood pressure. Sometimes in the back of a noisy ambulance, this is impossible to do. So this is one way we can at least get a portion of the blood pressure. The only thing this will represent, though, is the systolic. We will not get a diastolic during this procedure. First, locate the radial pulse. Making sure your patient is in a comfortable seated position. Expose the arm. Place this blood pressure cuff, again, over the brachial artery. Feel for a pulse again, a radial pulse. As I pump it up, I will continue to feel it, and at the point where it goes away, I'll add about 20 or 30 millimeters of mercury, and then slowly allow the air to release. At the time the pulse returns, there is my systolic, and I'm done. This is only going to give me the top number or the systolic. And the way you'll represent this on your documentation is to put whatever number the systolic is, we'll say 120 over a P to indicate this is by palpation.
Okay, so shush. Now I'm going to click on the next link, and it's on this next link on the slide where I want you at around time 2 minutes and 30 seconds. Look at the dial that is in the video and write down the millimeters of mercury for that systolic pressure. And you're going to use that value in your lab manual to answer the questions, and we'll take some time to do that. So hold on, let me share my screen again. Can you all see this screen, how to palpate a blood pressure?
Yes.
Okay. All right, so again, around 2 minutes and 30 seconds, I'll pause the video so you can write down the value on the dial that we see in the video so you can use that as your data.
Hey YouTube, welcome to another video from Skinny Medic. I wanted to talk to you about how to palpate a blood pressure. Now this is normally a little different than you would oscillate a blood pressure. When you oscillate a blood pressure, you get a top and a bottom number, a systolic and diastolic number. But this only gives you the top number. And in a noisy environment or an environment that's moving, bouncing down the road, this works great. Of course, you can see has a gauge here. This is going to tell us what our systolic blood pressure is, meaning the top number is when we go to palpate our blood pressure. Has Velcro. This goes around the patient's arm, the upper part of the arm where the bicep is, just above the elbow. Put the Velcro on. Tighten this down, righty-tighty, lefty-loosey. And as you pump it up, the gauge is going to go up in pressure. And then once we get to the point where I'm going to talk about, you lower it down, undo this just a little bit. You don't have to open it wide open, just start to turn it, and you can see our pressure gauge starts to fall. When you go to palpate a blood pressure, the most important thing is that you have a radial pulse. And you can feel the radial pulse if you go underneath the patient's arm here, down the thumb side, and put 2 fingers right there. You can feel a ridge, and you should be able to feel the patient's pulse. A common mistake people make is they try to feel a pulse with their thumb. If you do that, you're going to feel your pulse because you have a pulse in your thumb. So 2 fingers here. Don't put your thumb. 2 fingers. And I can feel my pulse there. So if you're going to palpate a blood pressure, you have to have at least a radial pulse. Also, just a key bit of information, if you have a radial pulse, that means you at least have a blood pressure of 80 systolic. So we have one hand on our radial pulse. Your other hand is on this bulb, and we've got it tightened. The valve's tight here. Start pumping your blood pressure up. And at some point, you're going to lose your radial pulse. Give it just a few more pumps to make sure we're well above our point that we're wanting to measure. And then open this valve up just a little bit, and you're going to see the needle start to fall. You don't want to open up too much because your needle's going to just race down like that, and you're not going to be able to tell what your blood pressure is. So slowly release the valve with our finger on our radial pulse, and we should not have a pulse, hopefully at this point for me. And then as the valve starts going down, you will regain a radial pulse. And the moment you feel the radial pulse come back in the arm, note where the needle is.
Okay. Hopefully you're writing down that pressure.
On our gauge here, and that is your top number. That is your systolic blood pressure. I hope this video helped you. You never know when you'll be the first responder.
Okay, so that was the palpatory method. Now I'm going to share the screen and get us back to my PowerPoint, and we'll move on to the auscultatory
For
method.
women that want to remove their dark spots,
No, I like my
potatoes
dark
are
spots.
amazing. When I first heard about this weird dark spot remedy,
Shush. Gotta love YouTube where it just starts automatically playing the next video for you all. Come on. There we go. Okay, so hopefully you have written down that palpatory systolic pressure, and as the gentleman said in the first video, you write down that value over the letter P so that everyone knows that you only have one value because you use the palpatory method. Now we're going to watch the video on the auscultatory method.
I have a question.
Mhm.
When you said, or when the lecturer was saying how this method underestimates about like 20 to 30, why don't we add 20 to 30 to the numbers?
Because that's not what you measured.
Oh, okay.
Don't assume.
Got
So
it.
here's what we are going to say. It is an underestimate. It is an underestimate. For some people, it might not be that much of an underestimate, but it is definitely an underestimate. It will be a higher value for sure. And the woman in the video did correctly say, if you can feel someone's pulse minimally, that means a systolic pressure minimally of 80 millimeters of mercury. These are guidelines. For us, for testing purposes, we want you to know the difference between palpatory and auscultatory. That palpatory is an underestimate, and you cannot use the palpatory method to determine someone's diastolic pressure. Good?
Yes, thank you.
Okay. All right, so let's watch. I'll just pick the first video. Let me stop sharing my screen. Take us to the YouTube. Okay.
California homeowners, if you have a power meter like this on the side of your house, you
Excuse the
can qualify
ads.
to be raise your energy bill at no cost to you. There's a California state. Hi.
Okay, so let me share my screen now. This is a longer video. Not too horribly long, but it's a longer one.
I'm Josh Farquharson, and welcome to Blood Pressure Audio-Visual Coordination Skills. There are several steps involved in taking a blood pressure measurement, and each step must be completed with accuracy. This is especially true when viewing the blood pressure dial and listening with the stethoscope. You must be able to effectively coordinate what you're hearing with what you're seeing. Just imagine if you recorded a patient's blood pressure as normal, when in actuality, their pressure was extremely high and they were at risk for having a stroke. Your inaccuracy can have dire consequences on the patient's overall health. This lesson will help you achieve accuracy when taking blood pressure measurements. By the end of this lesson, you will identify and interpret the graduation markings on an aneroid sphygmomanometer dial, and determine the systolic and diastolic blood pressure by reading the dial and listening to the Korotkov sounds. If you ever had your blood pressure taken, you likely noticed that the results were stated as one number over the other number, such as 120 over 80. The number on top, in this case 120, represents systolic pressure, and the bottom number, in this case 80, represents the diastolic pressure. Let's take a close look at the dial used for determining such a measurement. This is the aneroid sphygmomanometer dial, also known as the blood pressure dial. The dial has the letters mmHg because blood pressure is measured in millimeters of mercury. Also on the dial, you'll notice that there are lines in various sizes. The largest lines represent values of 20. This is 20, this is 40, 60, and so on. The medium lines represent values of 10. This is 30, 50, 70, and so on. And the smallest lines represent values of 2. So this line represents 22, 24, 26, 28, and so on. Now let's use the needle to determine the number displayed on the dial. Concentrate on the tip of the needle and the line that it's pointing to. How much does this line represent? If you stated 68, you are correct. So how much does this line represent? If you stated 112, you are correct. And how much does this line represent? If you stated 294, you are absolutely correct. Great job. Now that you're comfortable with reading the blood pressure dial, let's apply audio-visual coordination skills. And for this, please increase your volume level and have a pen and paper on hand. There are two main areas that you need to focus on when determining a blood pressure reading. 1, the position of the needle on the dial, and 2, the Korotkov sounds. We will refer to the Korotkov sounds as thumping sounds for the duration of this video. When you arrive at the point of the procedure, when you slowly deflate the cuff to hear the sounds, you will notice the needle move in a counterclockwise direction. It is at this point that you need to listen very closely for the thumping sounds. Upon hearing the first thump, note the needle's position on the dial and record the number. That's the systolic pressure. As the cuff deflates and the needle continues to move, you will continue to hear the thumping sounds. Listen closely for the last thump. Upon hearing the last thump, note the needle's position on the dial. That's the diastolic pressure. Let's practice applying these two steps. Please note that your answer may be slightly different from what's displayed, but that's okay. As long as your answer is within 4 millimeters of mercury, your answers are still considered accurate. For example, if the displayed answer is 120/80, but your answer falls somewhere in the range of 118/78 through 122/82, your answer is still considered accurate. Of course, matching the displayed answer is the goal to achieve the most accurate answer. We'll use 114/76 as an example. All right, so now that you know the basics, let's try a few simulations. Listen closely and write down your answers. I will reveal the correct answer once the simulation ends. Here's the first one. Try another. Okay, and let's try one more. So, did you answer all of them correctly? Great job. Give yourself a huge pat on the back for a job well done. There's so much more to learn about blood pressure, especially when it comes to the terminology, ranges, and the many steps involved in the process. Continue to discover, review, and practice as much as you can to master the art of measuring blood pressure correctly. And there you have it. You have learned to identify and interpret the graduation markings on an aneroid sphygmomanometer dial, and determine the systolic and diastolic blood pressure by reading the dial and listening to the Korotkov sounds. To stay up to date on other allied health learning tools, you can follow me on Twitter at AHTools1 or subscribe to my Allied Health Tools.
Okay, welcome back. How about you all take some time to answer some of the questions in your blood pressure section of your lab manual. Just take some time to do that. Hopefully you were able to write down at least one of those, 3 to 4 opportunities to write down systolic and diastolic pressure. So take some time for that. And it is 10 to 7. So how about you all take until about 7:05, and then I'll introduce the central venous pressure lab, and we'll have a quick break, and then we'll analyze the central venous pressure lab. So take some time to answer your questions in your lab manual.
Excuse me, is it page?
Central venous pressure abbreviated as CVP, is the pressure in your right atrium. That is technically where central venous pressure is, though oftentimes it's measured from just a little bit above the right atrium in the superior vena cava, but technically it is the pressure in the right atrium. And this should be about 0 millimeters of mercury. But it can change. It can become a negative number and it can become a positive number. It can get as high as 20 to 30 millimeters of mercury. What can change your CVP? What can make it elevated? You can have a faulty valve on the right side of the heart. Maybe you have a prolapsed AV valve on the right side of the heart, or a stenotic pulmonary semilunar valve. If blood is damming up in the right side of the heart, all the way back to the right atrium, blood damming up instead of moving from the right atrium to the right ventricle out through the pulmonary trunk can cause your CVP to go up. Why would this be a problem? Well, it's a problem if we consider that normally the pressure in the right side of your heart is supposed to be 0. And I'll remind you that when the left ventricle contracts and kicks out blood, that pressure can be about 120 millimeters of mercury. Blood only flows from high pressure to low. A normal value from the left ventricle of 120 minus a normal value for the right atrium of 0 gives us a pressure gradient of 120. And that ensures that the stroke volume, a typical stroke volume is 70 milliliters per beat, circulates through your entire systemic circuit and returns to the right atrium. A typical venous return is 70 milliliters. What goes out of the left side of the heart must come back on the right side of the heart. If your central venous pressure goes up to 20, then you would have a pressure gradient of 120 minus 20, and that would be a gradient of 100. That is not as strong of a gradient as the previous example. You would not have as much blood returning to the right atrium. There isn't as strong of a pressure gradient. We can also have changes in our CVP if we are giving a patient an IV saline solution and their blood volume is changing in real time. That can lead to more venous return to the right atrium. More blood returning to the right atrium will elevate central venous pressure. But that should be temporary because on the next beat, that increased amount of blood that has returned should be on its way out to the pulmonary circuit. We also can get negative values. Whoa, my computer just fell backwards. We can get negative values for CVP, like when we're exercising. When we're exercising and we're breathing harder, we have our skeletal and respiratory pumps. This can actually lead to a more negative value for our CVP, in which case, let's say our left ventricle generates a pressure of 120, and now we have a pressure, let's say, of negative 10 for our CVP. And you can quickly see that a negative of a negative means a positive. And this would be a gradient of 130 millimeters of mercury. So when you're exercising, your heart is actually becoming more efficient as a pump. Your CVP is becoming more negative, and it's almost like it's sucking the blood back from the systemic circuit back to the right atrium, almost like you sucking on a straw. So CVP does change. Now, when a patient has an elevated CVP, chronically elevated CVP. You can tell this because their veins in their neck, let me go back a slide, will actually be bulging like their jugular veins. You see, blood should be returning to the right atrium very easily through the superior and inferior vena cava. And if a person is sitting up, well, blood should easily be draining from the head back to the right atrium. But if blood is damming up on the right side of the heart because of an elevated CVP, the blood will also dam up in the veins in the neck, and you'll see bulging neck veins. This lab on CVP seems deceivingly easy. It is not. There are actually 5 different components to this lab that we are trying to learn. Excuse me, I have to plug in my computer. 5 components, and I'll address that on the next slide. Before we go for our break, I want you to see how clinically they actually measure a person's CVP. And then you'll appreciate how close we are doing it in our lab together tonight. Can you all see this video that I'm sharing now?
Yes.
Okay.
Another way of approximating central venous pressure can be done using the extremities in patients with visible veins. As you see here, as the patient's arm is lifted up, his veins disappear. And then again, as you bring the arm down, the veins reappear.
You see them bulging? And now they're not bulging.
Again, we'll bring the patient's arm back up slowly, watching for the veins to disappear. The moment the veins disappear, we keep the arm still and draw an imaginary line horizontal, parallel to the ground, above the patient's heart. The imaginary line is shown here. Next, we measure the vertical distance between the sternal angle and our horizontal line. After adding 5 more centimeters to account for the distance between the heart and the sternal angle, we have our total approximated central venous pressure using the arm of a patient. One last thing to mention, whenever using peripheral veins like the external jugular or veins in the arm like shown here, an obstruction of the veins due to the valves can lead to an overestimation of the central venous pressure. It's always best to use multiple modalities to estimate central venous pressure whenever possible.
So tonight, you are going to see a video of my husband. He's my little guinea pig, and he's going to be raising his arm. And when he is resting comfortably and he's raising his arm, I use the camera so you can see the veins on the back of his hand and how they collapse as he raises his arm. Why do they collapse? Why in the video that you just saw, when the doctor was raising the patient's hand, did the veins collapse? And I want you to see this picture here. There are natural pinch points where the veins coming from the extremities, like your arm, are turning the corner of your axillary fossa. That's a pinch point. And when someone raises their arm, you unpinch that area, and the blood can more easily return to the heart. When your arms are down, it almost crimps your axillary vein, and then blood dams up in your peripheral veins near your hand, and that's why they start bulging. So it's a pinch point, like a traffic point. If you unpinch, then the blood can easily return to the right side of the heart. Okay, well, here are the 5 things that we are centered on for this lab. Number 1, you should know what central venous pressure is by the end of tonight. It is the pressure in your right atrium. You should also know that it can increase and decrease, and what are some reasons why it can increase or decrease. Second, we are actually going to simulate, pretend that my husband in one of the videos has an elevated central venous pressure. We are going to simulate that he has a valve problem in his right heart, maybe his tricuspid. Maybe it's stenotic, and the blood does not flow from the right atrium as easily into the right ventricle. So there's actual versus simulated. So you're going to see a video where he's just raising his arm and he's not holding his breath. And then he's going to hold his breath and he's going to repeat the experiment. When he holds his breath, he's going to do this. He's going to take a deep breath and hold his breath and bear down like he's going poo. That's called the Valsalva maneuver, and that's called the breath holding phase. And when he bears down, trying to exhale, but he doesn't let himself exhale, what he is doing is damming up blood in his right atrium. And his veins start bulging more. Again, he's simulating what it would look like if someone had an elevated CVP with bulging veins. And when his veins are bulging, he will have to raise his arm higher to unpinch that pinch point to get the blood to go back to his right atrium. So without holding his breath, he doesn't have to raise his arm as high, and we see his veins collapse. When he holds his breath, simulating an elevated CVP, he will have to raise his arm higher before his veins collapse. So that breath holding phase is part of a technique I just said called the Valsalva maneuver. We will want you to know the phases of the Valsalva maneuver. When you come back from your break, I will go through the phases of the Valsalva maneuver. And then as we talk about the phases of the Valsalva maneuver, this brings up conversation about your baroreceptor reflex arc. So that's another fourth concept. Do you understand your baroreceptor reflex arc? And then lastly, we talk about how manipulating the Valsalva maneuver can actually be helpful to someone who has supraventricular tachycardia. Supraventricular SVT, supraventricular tachycardia. But your patient has to be coached right in order to have this Valsalva maneuver to convert their SVT into a normal sinus rhythm. So go take a 10-minute break, and when you come back, we'll watch the videos of my husband and we'll see him normal, not holding his breath, no Valsalva maneuver, and we'll take the measurements. And then we'll see him hold his breath, holding the Valsalva breath holding phase. And you'll see that he has to raise his arm higher before his veins collapse, before we overcome that pinch point, that crimped point. Okay, go have a nice 10-minute break. I'll see you at 7:30. So again, central venous pressure is the pressure in your right atrium, and it is supposed to be 0 millimeters of mercury. However, it can and does change. Today, we are going to watch two videos with my husband as our patient. The first video, he will be raising his arm. Again, when you raise your arm, you undo that pinch point and you allow blood to return to your right atrium. Then in the second video, he's going to be holding his breath. When he holds his breath, that's called the breath holding phase of the Valsalva maneuver, and I'll explain that in more detail in just a moment. He is simulating, he is pretending that he has a valve problem and he has an elevated central venous pressure. When he does that, it dams up the blood. It blocks venous return to his right atrium. So all the blood dams up in his peripheral veins. We say his PVP, peripheral venous pressure, is going up, and he starts getting the bulging veins. And then he has to raise his arm higher to overcome that pinch point to allow blood to go back to his right atrium. There is a chart that you're going to want to fill out on page 28 of your lab manual for the holding the breath versus release phase. But first, let me teach you about the Valsalva maneuver before you fill out that chart. Okay, so you're going to have to write down data for where he is on the ruler when he's not holding his breath, when he's at rest. This is at the top of page 28. There's a line for you to put your data in. And then under step 3, there's another line where you can put your data in for when my husband is holding his breath, and you're going to see that he's higher up on the ruler. All right, get your pencils ready and we'll watch this video. Again, this was the very first video we did after the pandemic hit. So it was just very, hey honey, I need your help, lay down on the floor and hold your breath, pretend you're pooing. And he's like, what am I doing? I said, you're helping students, trust me, it's a good thing. Hello, students. I am now going to demonstrate. Can everyone see this video?
Yes.
Okay.
Yes.
Okay. The central venous pressure lab. The first part of this experiment, you have your subject laying down and you have a meter stick. And the idea is to put the meter stick between your fellow student's chest on the left side where the heart is mostly located. And you're going to record the inches, or not the inches, but the centimeters in height that the person will raise their arm. Notice down here, we have some nice bulging veins, and we're going to look for those veins to collapse as the subject raises his arm. You're going to slowly raise your arm up until I say stop. Stop. So the subject's veins clearly have collapsed. And now I look at down here where the top of his arm is, and you record that in centimeters. Okay, can everyone see on the right-hand side of the ruler are centimeters?
Yes.
Okay, so you need to arbitrarily at this point, because we're watching a video, pick where you think the top of, like, can you see my pointer? Can you see my pointer?
Yes.
Okay. So I'm just arbitrarily, because he's got his sleeve here, I'm just looking straight across from his sleeve over here to the meter stick, and I'm reading that in centimeters. But you might pick down here closer to his heart, whatever you want, just pick a value here on the meter stick in centimeters. Did everyone write down a value at the top of page 28? And remember, for every centimeter, there are 10 millimeters. So in your lab manual, you will need to convert these centimeters into millimeters. Just multiply by 10, and you will have millimeters. All right, moving on. To the best of your ability. Okay, pause. So now the second part of the experiment is where the subject performs the Valsalva maneuver, specifically the breath holding phase. Again, we're looking at centimeters, which is on the right-hand side of this measuring tool. Go ahead and start holding your breath and bear down as if you're having a bowel movement. Hold that for a while. Again, look at the veins starting to distend. Keep holding that breath and slowly raise your arm, please. Veins are still bulging, keep going, stop. Now, the hand is definitely much more elevated this time than it was before. And again, here is the perspective for how. So can you, I'm trying to expand my video.
When China's Communist Party wanted access to Donald Trump, Michelle steals.
Hello, students. I am now going to. Sorry about that. I was trying to expand. The hand is definitely much more elevated this time than it was before. And again, here is the perspective for. Okay, so I hope you can see, let me get to full screen. Maybe that will be helpful. Can you see the values on the right side? How high? So that's 24 right here where my pointer is. Here's 23, here's 22. He's definitely higher up now than the first video. So write down a number now that he's doing the Valsalva maneuver. The arm is. Compare that to the previous film shot. You can breathe. Sorry, I forgot to tell you that. But clearly the arm is elevated. All right, good job. All right, so
having these in every room means you'll.
All right, let's go back to our PowerPoint. Let me explain to you what the Valsalva maneuver is. There are 4 phases to the Valsalva maneuver. However, phases 1 and 3 are very short-lived. They are transient. They are not long-term. Phases 2 and 4 are the phases that we want you to know the most. Down here, you can see that phase 2 is the breath holding phase. If we were face to face, I would be telling you all that tonight I'm teaching you how to properly defecate. You all probably thought you knew. The Valsalva maneuver is a procedure we all have used when we defecate. If you look like this when you defecate, ready? That is not the proper way to defecate. Holding your breath like that and bearing down for a long period of time means you're holding this holding breath phase 2 for a long period of time. What does that mean? When you hold your breath like that and you bear down, trying to exhale on a closed glottis, you are not allowing blood to return to your right atrium. And that means the blood dams up in the periphery. That is the reason why the peripheral venous pressure goes up during the breath holding phase. So my husband doing that technique was simulating, he was pretending to have an elevated central venous pressure. But here's the reality. The reality is when you hold your breath like that and you bear down, your central venous pressure is actually becoming negative, not positive. Again, this is where this lab gets challenging. There's what we're trying to mimic, and then there's actuality, reality versus mimic. We want you to know both. And that's why on page 28, you have that chart to help you. Use arrows for up or down to talk about CVP versus peripheral venous pressure and what is happening with your heart rate. As you hold your breath and bear down, your CVP in actuality is going down. You're not allowing venous return. And that means on the next stroke out, your stroke volume has gone down. You haven't allowed venous return. So your stroke volume goes down during that breath holding phase. And here's what happens. I'm just jumping. If you have reduced stroke volume because you're holding your breath, then the baroreceptors, which are found in the aortic arch and carotid sinus, are detecting less stretch. They fire action potentials up to your medulla oblongata, but at a reduced frequency. So the firing is reduced. I'm answering your little chart on page 28 right now. Because the medulla oblongata is receiving fewer action potentials, there is going to be a resulting sympathetic output. And that means your heart rate goes up. So keep that in mind. Next time you defecate and you're holding your breath, trying to poop, the more you're holding your breath and straining to defecate, the less blood you're allowing to return to your heart, the lower the stroke volume your heart will have, the fewer action potentials the baroreceptors will send up to your brain, and the resulting output from your brain will be an increased heart rate. And your heart rate is going up while you're straining to poo. What happens to your TP segment then if your heart rate is going up? Isn't that an important time for your heart? It's the time for your heart to rest and fill and be perfused. So straining to defecate kills people. This is a public safety announcement. It kills people. People don't know how to breathe through the defecation. And by the way, you shouldn't be straining that hard in the first place. Eat more fiber. Take care of yourself. Hydrate more. People oftentimes die on the toilet in the morning when they're having their bowel movement. It is not uncommon for paramedics to be called to someone's house to pick up a dead body, and 9 times out of 10, it's in the bathroom. That body's in the bathroom. And they were trying to have a bowel movement. You don't want to hold your breath and bear down and strain and strain and strain to have a bowel movement. Your venous return continues to go down. The baroreceptors fire less frequently, and your heart rate goes up, and your TP segment shortens. That is not what you want to do. So again, that's all when your blood pressure goes down, when your stroke volume goes down, your heart rate goes up. That's the breath holding phase. What about the release phase? What about the release phase? You heard me in my video tell my husband, oh, sorry, forgot to tell you, you can breathe now. That's phase 4. And phase 4 is the rescue phase when someone has a supraventricular tachycardia. The release phase is the part that is helpful clinically. So we want, if a person has elevated heart rate, we can use the Valsalva maneuver, the breath holding and then release, breath holding and then release, phase 2, phase 4, and help them get back to a normal heart rate. But you need to coach them very carefully, because if you say to them, hold your breath and bear down like you're having a bowel movement, they might hold their breath much too long, eager to show you, their nurse, how good they are. So you need to coach them carefully. What's another way you can tell your patient to hold their breath for a short amount of time, bear down, and then release? Hold, bear down, and then release. Ask them to cough. Watch. A cough is a perfect application of the Valsalva maneuver. You take a deep breath in, you hold it, you bear down, and then you exhale. On the exhale, the release phase, as it's written on this slide, allows more venous return. All that blood had been dammed up, and now it can come back to the right atrium of the heart. More venous return, more in on the next beat, more out of the heart. Stroke volume goes up. And when stroke volume goes up, the baroreceptors detect more stretch and they fire more frequently. More action potentials up to the medulla oblongata will be a resulting output for the parasympathetic division, and this will lower the patient's heart rate. That's the rescue part that we're looking for when we're trying to help a patient through supraventricular tachycardia. So let me show you how in a clinical setting, they actually use this Valsalva maneuver to help convert someone with supraventricular tachycardia.
Join hundreds of thousands of California drivers in supporting Prop 22. By a 4-to-1 margin, drivers want to stay independent. That's why we need Prop 22. Drivers need flexibility and benefits. Prop 22 provides both. Join me in voting yes on Prop 22.
Or not if you don't want to.
All right, guys, imagine yourself sitting at home, relaxing, watching TV. Then all of a sudden, your heart rate jumps up from a normal to 150 to 250 beats per minute.
It's probably the most common and most scary experiences to go through. SVT is the topic today, aka the merry-go-round from hell. I'll explain the pathophysiology of why we call it this in just a little bit. But first, what exactly is SVT? Well, supraventricular tachycardia is episodes of rapid heart rate that starts in a part of the heart above the ventricles. Which makes sense because supra means above, ventricular means the ventricles, and tachycardia is heart rate over 100 beats per minute. So what's really going on in the body here? Well, as you guys know, the heart has one main pacemaker and two backup pacemakers. In this case, our main pacemaker, the SA node, fires like normal, but the problem is somewhere near the AV node area. The charge jumps from normal conduction and kind of derails and jumps the train tracks. Instead of going down to the ventricles, it goes right back into the atriums, essentially doubling the amount of beats per minute. It's kind of like a merry-go-round from hell. This is why SVT is so dangerous, because it's that merry-go-round from hell. It's super rapid and very, very deadly, making your heart go like extremely fast. So using our 5 steps, let's interpret this EKG. Step number 1 is the rate, 150 to 250. That's like super fast. Step 2 is the rhythm. It's regular, guys. It's evenly spaced apart. Step 3 is our P wave. The atriums are contracting, but it's usually buried in the T wave. Now, step 4 is our PR interval. Usually it's not able to measure because it's going so fast. And lastly, step 5, our QRS is normal and narrow. Now, the causes of SVT. What causes this merry-go-round from hell? Well, the main causes are quite simple. We use the 3 S's: stimulants, sepsis, and stress. So stimulants like caffeine, cigarettes, and alcohol, which I call the 3 wise men, but even exercise can stimulate the heart rate and make it go buck wild. Now, sepsis, just fancier words for infection in the blood, can cause fever and added stress to the body. Even stress like anxiety from normal daily emotional struggles. We have to read all these pages? But also diseases that put added stress on the heart, like CAD, that cause the narrowing of the coronary arteries and puts added stress on the heart. Or CHF, known as heart failure, increases blood pressure and puts pressure on the heart. And also myocarditis and rheumatic heart disease, known as rheumatic fever, both cause inflammation in the heart, and even COPD, chronic obstructive pulmonary disease, makes it difficult for the body to get oxygen, which ultimately adds stress to the body. So what are the signs and symptoms of SVT? Well, once again, they all stem from this low oxygen, this low cardiac output. We'll see classic complaints like, I feel lightheaded or I may pass out. So we use our cool little acronym COLLAPSE to describe all the problems that low oxygen gives our patients. And yes, guys, we did spell it wrong on purpose, so please don't email us. Now, C is for chest pain, O is for oxygen saturation that is lower, L is for lethargy or fatigue caused by this low oxygen, A is from anxiety, usually caused by that lack of oxygen, P is for palpitations, that described as a racing of the heart or kind of feels like gallops under the chest, S is for shortness of breath or dyspnea, that difficulty breathing, E is for elevated ventricular rates or heart rate in general, huge indication of SVT. You're going to have a very tachy heart rate. D is for dizziness and syncope, which is also called fainting or passing out. All right, so now that we know what's wrong, what are we going to do about it? So here are some nursing interventions and treatments. But first, what is the main patient outcome goal? Well, we always want to reset and restore the heart to normal electrical function. So we use non-drug interventions first. So guys, write that down, please. First things first, we use a Valsalva maneuver, also known as a vagal maneuver. We ask the patient to bear down like they're pooping. Now this elicits a vagal response and drops the heart rate. Now I've even seen people use ice packs around the neck, which can elicit a vagal response too, because they kind of like tense up. Now, if that doesn't work, we use good old-fashioned pharmacology. So the first things first, adenosine will lower the heart rate immediately, but it'll actually stop the heart rate too, and the patient will die if we give too much. So before we give it, there's some things that need to take place first. For example, the patient needs to sign a consent form, the doctor needs to be at the bedside, there needs to be a crash guard in the room, the patient has to be on the EKG monitor as well as the cardiac monitor. Woo! That's a lot to check off here. And we got lunch. Perfect. Now, if the drugs aren't working, we can always opt out for cardiac ablation, which is basically just burning or freezing the cells in the heart that are causing the problem. Or we can do electrocardioversion, our little baby shock. It's only 50 to 200 joules of electricity. It's given to reset that SA node, the main pacemaker of the heart. Now, once again, cardioversion is mainly used for AFib or A-flutter, but also for SVT. We're always going to want to do a TTE, a transthoracic echocardiography, which basically is a procedure to rule out clot formation in the atriums. Before we shock the heart, we don't want to spread those clots all over the body. Now, a little NCLEX tip for you guys. Cardioversion is not defibrillation. Defibrillation is that supersized shock at 200 to 360 joules of electricity. It's usually done when we have deadly rhythms like VFib or pulseless VTAC. Now, lastly, when the patient is stable and they're going to get discharged from the hospital, we need to educate the patient about the prevention and limit of triggers. And remember, the triggers are the 3 S's: stimulant, stress, and sepsis. They also may be prescribed drugs like the B, C, and D, beta blockers, calcium channel blockers, and digoxin. All are given to slow the heart rate and keep that even rhythm. I call them the famous negative chronotropic drugs because chronos meaning time, so negative time means less beats per minute. Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And
Okay, that was a lot, wasn't it?
I have a question.
Yeah.
When did we say it stopped the PR interval?
When did we say it stopped the PR interval? He was just,
We won't see it.
he was saying if the person's heart rate gets really high, that you might not be able to measure the PR interval because the P wave ends up being consumed, masked by the T wave. But
Okay.
he did not state how many beats per minute that actually happens.
Okay.
Okay, so here is another video.
I'm Andy Applebaum. I'm the Chief Investigator.
Can everyone see the video?
Yes.
Yes.
In the REVERT study. And I'm also a consultant at the Royal Devon and Exeter Hospital in the southwest of England. Hello there. Hi. I see from your heart tracing that you've got a condition called SVT. The REVERT trial was a randomized controlled trial to look at a method of modifying the Valsalva maneuver for the treatment of SVT. Asked you just to get a good seal around that with your mouth and blow hard enough to make the needle reach the top. Modification was designed to increase venous.
So they're going to have him blow into like a straw. And if you think about when you go to a straw and you're going to blow in it, you take a deep breath in and you bear down. Especially if it's a very small diameter straw, you would have a lot of resistance in that straw. You'd have to push harder. The idea is when you coach a person to do the Valsalva maneuver, you don't want them bearing down and holding their breath for a long time. Understand when a patient is in your care in the hospital and you ask them to do something, oftentimes they want to show you how good they are at doing what you ask them to do. So if you say, bear down like you're pooing, they're going to most certainly hold their breath and bear down for a long time to show you just how good they are at that. And that can actually make their elevated heart rate worse, not better. We want the release phase. When we release, we allow more venous return. On the next beat, a better stroke volume, baroreceptors will fire more frequently, and the resulting output from the medulla oblongata would be a reduced heart rate.
Return during the relaxation phase of the maneuver and involve laying the patient flat and lifting the legs in the air at the end of the strain phase. Overall, we found that patients that were randomized to the standard maneuver, only 17% of patients were cardiovert to sinus rhythm, whereas for the modified technique, 43% of patients return to sinus rhythm. It really does demonstrate marked improvement with a modified technique. And I think we should consider using that as a standard approach to the initial treatment of this condition. 5, 4, 3, 2, 1, and just completely relax. Lift your legs up in the air. So we used a blood pressure manometer that was modified for the trial, and that can be done in emergency departments, but in other practice or usual practice, a 10 ml syringe blowing just hard enough to start moving the plunger, we believe gives a similar sort of pressure. So you ready? And ready, steady, blow. And the benefit of that is that patients can use this at home and outside of the hospital, because it's a condition that can recur. And that gives the patient some control, and may mean that patients don't need to come to hospital in the first place. Okay, I'm going to sit you back up now. Okay.
All right, so notice that modified, that revert procedure where they're reclining the patient and elevating the feet. What is that actually doing? It's leading to more venous return. So he stops blowing, they put his head back, they elevate his feet, and now we're allowing a lot of blood to return to the right atrium. And on the next beat out, we're going to have a greater stroke volume. And that means the baroreceptors will detect more stretch. How about you take some time right now to fill in the chart on page 28. Again, just use arrows. Arrows for up if you think CVP is going up higher than normal, or down if you think CVP is going down compared to normal. Take some time to fill out that chart, and then I'll ask you what you put down, and we'll talk about it. And that will be the end of our lab then tonight. So take some time to fill out page 28, that chart, to the best of your ability. All right, so let's look at our data for our chart for the breath holding phase. That's phase 2. Can anyone tell me what they put down for the actual central venous pressure in a patient, in you, when you're holding your breath and bearing down? What is actually happening to the pressure in your right atrium and why? No one put anything down?
I put it's going down.
I put going down.
I think that I don't know the reasons.
It is going down. Can anyone tell me why?
Because the pressure is compressing the vena cava.
Correct. So when we hold our breath, we are creating more of those pinch points. And we're compressing the veins. Remember, veins don't have a thick tunica media, so they're pretty easy to collapse. So correct, it is going down because we're creating more of those pinch points, the compression. We're kinking off the blood flow. So meanwhile, the blood is damming up. So what is happening to your peripheral venous pressure?
It's going up.
It is going up. Good. And if our blood is damming up in our peripheral veins, are we getting good venous return?
No.
No.
No, we're not. That's why our CVP is going down, because we're not getting good venous return. So on the next beat, if we have less in, what's our stroke volume going to look like?
It'll
Down.
go down.
It will go down. Good. And then what will our baroreceptors detect in the pressure of the aortic arch and carotid sinus? If there's reduced stroke volume, will there be a lot of pressure or little?
A little.
Would be going up, right?
No, it'll be going down.
Aortic pressure will be going down. Aortic pressure is going down. You see here in phase 2, the breath holding phase, because we're not getting a good stroke volume. So then there's very little distension in the aorta. So aortic pressure is going down. And then the baroreceptors are going to detect less stimulus, so their firing rate will also go down. And then the resulting output from the medulla will be to increase heart rate. So that is the reason why our heart rate goes up as we're bearing down to have a bowel movement. So again, your arrows in order should be down, up, down, 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 up. Did everyone get that?
Yes.
Down, up, down, 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 up. Now, how is that going to look differently when we release? Phase 4 is the release phase. How are those arrows going to change? Well, when we release our breath holding phase, when we allow ourselves to breathe, those pinch points are no longer pinched. So we're going to have increased venous return. We will have an increased central venous pressure. We will have decreased peripheral venous pressure because now we're allowing the blood to come back. And on the next pump out, we're going to have a good stroke volume. And the baroreceptors are going to detect that. There's going to be a lot more aortic pressure, and the baroreceptors will fire more. And the resulting output will be a decreased heart rate. And now we have rescued our patient from supraventricular tachycardia. So those arrows for the release phase should be up, down, up, 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 down. Good.
Good.
All right, my sweets. Well, do you have any questions for me in these last 8 minutes or so of class?
I have one question. Since the homework packet, or I mean, since the test has been pushed back, we said the homework packet was due
This Thursday.
This Thursday. Okay.
Thank you for reminding me to mention that. That was on my mind to make that announcement. Yes, your homework packet is due this Thursday. Please also remember to send me your voting extra credit. Either you're sending me a picture showing that you voted, or you're sending me a paragraph telling me what is important to you, and why, why is it important to you? And again, no judgment, no judgment, no judgment. I just want my students to care about something, anything, care about something. So no judgment. I'm happy if you're able to vote, and if you're not able to vote, eventually someday, I hope you are. And don't take it for granted. There are certainly a lot of people in other countries where they are not allowed this privilege, and it is one that we should do. I don't care who you vote for or what you vote for. I really don't. I'm just happy if you can vote, that you do vote. That's important. Let's give honor to the people that died for this right. That's what I think. My little political statement. All right, well, here's what we're going to do on Thursday. Thursday, I am going to give you a review for lecture exam 3. We're going to talk a little bit about the beast of the cardiac cycle. Students have asked me, on our lecture exam 3, what parts of the beast, the cardiac cycle, and that picture that I called the beast in that PowerPoint, they say, what will our picture look like? It's exactly like the one in your homework packet. Exactly. So we're going to go through the homework packet beast picture and make sure you're identifying an interval versus an instant. So we're going to talk about that. We'll talk about the lecture exam 3 review. And then I'm going to start talking about renal clearance values. We're starting lecture unit 4. You should already be into lecture unit 4. And again, Medina, I see your name. Medina, I did re-upload the PDF, and I believe you might be thinking that I talked about the heart anatomy and fetal circulation. That's the one that is transcribed. Or you might have been watching the pathophysiology cardiovascular problems. Maybe you accidentally got to that one. Anyway, the cardiovascular lecture for your class is not transcribed. There are some notes on some slides in the notes part, but it is not transcribed, and I hope I answered your question and addressed your issues. If I didn't,
thank you.
Okay.
Thank you.
Is PhysioX 9 due Thursday as well?
No.
Okay.
Nope. Nope. I want you all focused on lecture unit 3. I'll assign PhysioX 9 after that.
Okay.
Okay.
Thank you.
You're welcome. Are there any other questions?
Mrs. Carter, can I have a question, please?
Yes.
In the lecture, you say we have the capillary bed, and we know, and in the capillary bed we have it blocked. And is it capillary bed, is it permeable for transfer the nutrient to the tissues. So why they cannot, the red blood cell cannot be permeable to capillary bed or going to tissues? Why?
That's a great question. So the red blood cell has a diameter of about 7 to 8 microns. And the intercellular clefts, the space between the capillary cells is very small, Hassan. So the red blood cell cannot get through there. Okay, so the space for gases and nutrients and fluid, those can get through. Hassan, do you ever make pasta? Do you ever cook pasta?
I worked with the pasta's restaurant, but I didn't make it.
Okay, so you know when you cook your pasta, you pour the pasta in hot water into a strainer, colander, right? And it allows all the water, but the pasta does not get through.
Exactly.
Okay, so think of red blood cells like the pasta. They can't get through those spaces, but all the plasma and the nutrients can.
Mm-hmm.
Is that better?
Yes, that makes sense.
Okay.
Yeah. So the albumin is a very large protein, right? So albumin is on the plasma. So even albumin cannot go to interstitial fluid, right?
Not easily. A little bit might get through, but not most. Albumin is much too bulky, and it's not just about size. It's also about around the endothelial cells, there's a sheet of protein.
Mm-hmm.
And the basement layer. And that basement layer can also make sure that albumin does not get through as easily. So for example, if you were making your pasta and let's say you put a paper towel in your strainer and you dump the pasta and the water in the strainer with a paper towel, water will still come out, but maybe some of the water will still stay behind because you have a paper towel.
Yes.
Okay,
yeah.
so albumin a little bit might get through, but usually not a lot.
Understand.
Okay, good question.
Sure. It was my pleasure. Thank you for that.
You're welcome.